Thanks very much, and thanks very much for the opportunity to speak to you. I'll try and catch you up a little bit of your time. So if I can have, you can see the first slide on the screen. If I get the second slide, the relevant disclosures that I have to make in regard to this presentation are that the Australian National Health and Medical Research Council funds part of my salary and some funding for one of the projects that I'm going to talk about, and the salt substitute that we use in one of the projects that I will speak to is provided by the Jiangsu Shikang Technology Company in China. I've got the next slide. So I've just listed here three key publications to which I'll make some reference during the presentation. That's the next slide. So what I want to do here is give you a very brief background, and you've already had a lot of presentation about the science behind sodium and health. I want to talk to you a little bit about some pilot work we've been doing in developing our idea and our plans for doing a large-scale trial evaluating the effects of sodium on health. And then what I'm going to do is just give you, after talking through the challenges, a quick summary of where we ended up and where we're up to in terms of our salt substitute and stroke study. So if I can have the next slide, by way of background, I think there's pretty clear data that excess sodium raises blood pressure from the observational studies, and I think pretty clear data also from the observational studies that high blood pressure is associated with increased risk. The challenge, as we've heard, is that sodium intake is inconsistently associated with vascular risk in the observational databases. At the same time, we have randomized trial data which show that if you reduce sodium, you can reduce blood pressure. We know from other modalities of blood pressure lowering, it's a very powerful way of reducing risk, but we lack any adequately powered trial that defines the effect of sodium reduction directly on vascular risk. And so we have sodium reduction widely recommended, and my view is that the totality of the evidence suggests that sodium reduction is more likely to be beneficial than harmful, but we don't have every bit of evidence that we would like to have. And I think it's fair to say that on a global basis, sodium reduction is mostly not happening. So that's the next slide, which is titled Pilot Trial 1. So this is obviously not a new issue. We started working on this back in about 2005 when we identified what we thought might be an opportunity to try and address this question in a large-scale trial done in a Chinese setting. So we did our first piece of pilot work there where we took 600 individuals in a rural part of China, and I'll come back and talk in more detail about why we selected this particular place and population. And we randomized them to 12 months of salt substitute or usual salt. And we were able to show that we could achieve a blood pressure reduction in that setting, and we were also able to demonstrate a number of practical aspects of doing such a project. So I have the next slide. We then went on and did a second piece of pilot work with colleagues again in China and also in this case in the US too. And in this second piece of pilot work, we looked at a different opportunity. So we tested, instead of providing individuals with salt substitute on an individual basis, we looked at some alternative possible design strategies, and we used a cluster randomized trial where we assigned villages, in this case 120 rural villages in China, to receive either usual care, which basically was no intervention, or to receive access to education about how to reduce dietary sodium intake, and access to salt substitutes made available in the stores, but not actually provided to all of the individuals. So trying to test potentially a different strategy to designing such a project. Now, if you move on to the next slide, all of this and what I'm going to talk to you has led into the design and implementation of our salt substitute and stroke study. And as I say, I'll come back at the end of the presentation and give you a bit of an overview of where we got to. But before I do that, if I can have the next slide, I'd just like to consider what would be the optimal trial design if we wanted to ask the question, what is the effect of sodium reduction on hard human health outcomes, such as strokes, heart attacks, and the things that we as clinicians and our patients really care about. And I guess this is informed not just by thinking about the sodium question, but also by the many other areas in which we do these sorts of trials, and I guess particularly by work done looking at other modes of blood pressure lowering based upon primarily drug therapies. So I think the ideal trial would be a large-scale, international, randomized, double-blind project. I don't think I'd have a great deal of difficulty persuading most of the audience of that. I think we would ideally use representative population samples with a broad range of different characteristics, and particularly a broad range of different sodium intake levels. I think the intervention would ideally be based upon sodium reduced foods because for most of the world, most sodium is coming through foods that are consumed rather than directly through salt. And for the areas of the world where that's not the case, that's likely to change in coming decades as we see ongoing globalization of the food supply. In terms of an outcome, we need an outcome that, as I inferred, is really relevant to the people themselves and also to the policymakers and physicians and others who are supporting their long-term health. And I think this would be an outcome that's similar to that we use in the large-scale drug trials, strokes, heart attacks, vascular death, total mortality, and the like. It's also very clear from other areas that we need to have a really good understanding of what the events are, and typically there we would undertake an adjudication process where we would make sure that we know exactly what each event is, so that we understand, we maximize the potential for our study to detect the effects we're looking for, and we're able to make a really strong case about understanding what we have actually demonstrated. Goes without saying, we'd want excellent statistical power to test the question, and we would also want a series of subsidiary analyses that would give us information both about other outcomes that are important to patients and to policymakers, such as quality of life, cost effectiveness, and we'd also like, I think, to have a broad-based collaborative group that will give us the maximum insight into why the intervention that we undertook might have worked, but also how we might be able to translate that intervention into policy and practice if it were to show a positive finding. So have the next slide, please. And what I've done here is just list a series of challenges to doing this sort of a project. And I'm going to go through each one of these in turn, and I won't go through them here, but if I can have the next slide. I put at the bottom of the list funding, but I'm going to actually start with funding because it fundamentally affects everything we have done, probably more than anything else. There are very few ways to get the sort of money that is required to do these sorts of projects around the world. If we were trying to test the effects of a drug in a similar way, then we would be almost always trying to do that with industry funding support. And if we were doing this to meet the requirements for a regulatory process, either in the US, Europe, or elsewhere, we would be spending hundreds of millions of dollars to do such a project. Now, I think there's nowhere in the world that is going to provide that sort of funding for this sort of project, and I think there are no public good funding bodies that are going to provide that sort of funding either. So we've had to go about this in a much different way, and by taking a very streamlined approach to things, because the quantum of funding that we might like to have to do it really well simply isn't going to be available. Another key challenge is the duration of funding that's available. Certainly here in Australia, it's pretty hard to find any agency that will fund you beyond a 5-year project. A study of this sort of magnitude to detect the most plausible effects of sodium reduction on hard outcomes is pretty tough to do in a 5-year period, as you'll come to see as I talk through some of the next slides. Let's move to the next slide on statistical power. So clearly, if we're going to embark on an exercise like this, we want to be really sure that we identify truth at the end of the study, and that requires that we have a very good chance of picking up the most likely effect and a very low chance of identifying or ending up with a result that was simply the consequence of chance. Typically, in these sorts of studies, we'd like to have 90% power with an alpha of 0.01 to meet those criteria, but we will very often settle for something less, 90% power, alpha at 0.05, or maybe 80% power, alpha at 0.05. Just to give you an idea of what that might mean in terms of the sample size, if we wanted to detect a 15% relative reduction in the risk of a hard outcome like, say, stroke, that would require us, if we want 80% power and a p-value of 0.05, to have about 1,000 outcome events. And these sorts of outcome events occur pretty infrequently, even in populations that are enriched in terms of their level of risk, perhaps at about 2% per annum. So if we want to accrue 1,000 events, that's going to require about 50,000 patient years of follow-up, or 10,000 people followed for 5 years. So we're talking about a need to do a large project. If I move to the next slide, which is entitled Participants, I alluded to the fact that if we want to do a trial to test effects on a hard outcome, we obviously need to have a population that is going to have those events, because otherwise we won't get statistical power. At the same time, we don't want to choose such a unique set of individuals that the trial doesn't have generalizability to a broader population. And in almost every large-scale outcome trial in the cardiovascular space, we have to make a significant compromise here, because if we were to do trials in general populations looking for these sorts of outcomes, then we would literally have to include hundreds of thousands of individuals to complete the trial in a plausible time frame. Other key points in terms of participants, there's no point identifying a group that is going to have these outcomes that you can't then recruit, and this has been a common problem in many large-scale outcome trials in the drug space. We have to be able to follow those participants, and they have to be amenable to taking the intervention, to accepting the intervention that we're going to put in place. And that's actually probably more challenging in the dietary sodium reduction space than it is in the drug space, where we're able to provide simply a once-a-day or twice-a-day tablet or placebo. Much greater complexity in terms of delivering a low-sodium intervention. So let's move on to the next slide and just talk briefly about the intervention options. I mentioned earlier in my presentation that we've done a number of pieces of pilot work looking at different possibilities for reducing sodium in the intervention group compared to the control group. And broadly, we considered 3 options: education, providing low-sodium foods, or salt substitution. Now, it was pretty clear to us on reviewing the literature and also our own experience that simply telling people what they ought to do was an ineffective way of achieving a real difference between groups in terms of the amount of sodium consumed. So we really had to write off education as a plausible option for doing a trial. Providing a low-sodium food supply is clearly a very effective way of reducing sodium intake of a group of people, but it's also incredibly expensive if you're thinking about doing it for tens of thousands of people for years. And so, again, we had to write that off. We ended up with salt substitution as the really only plausible option for us, because it was a means which we had demonstrated could produce a fall in blood pressure that would be likely to drive a risk reduction. And it was something that we thought we could do in the population such as a rural Chinese population, where most of the dietary salt consumed is salt that is added to foods at the time of food preparation or at the table. And so we'd be able to get at a significant proportion of all of the sodium in their food supply. So if we now move to the next slide, which talks about follow-up, the key factor in doing these sorts of large outcome trials is completeness of follow-up. If you don't have completeness of follow-up, at the very least for vital status, but in the vast majority also for the cardiovascular outcomes like stroke, heart attack, that you're interested in, then you don't have a robust or a credible trial at the end of it. We spent quite a lot of time in our pilot work trying to understand what the options might be for follow-up. We looked at telephone follow-up, face-to-face, the use of routinely collected data, or some combination of the two. We also decided that we wanted to measure a series of process outcomes. So here I'm talking about intermediate outcomes such as sodium consumption, blood pressure during the course of the study, so that we could track whether the trial was having the anticipated effects on these intermediate outcomes that would be anticipated to drive the hard outcome result. And we felt that it was reasonable to track these because there's no uncertainty about the effects of salt substitution on these outcomes, but clearly we'd want to keep the effects on the hard outcome blinded. So let's move to the next slide. In terms of outcome choice, to maximize the potential for testing our hypothesis, we elected to look at a stroke outcome. The reason we chose stroke was that this was an outcome that was common in the population that we decided to study in rural China. In fact, it's the most common cause of death, and it's one of the most common serious illnesses that occurs in that population. We also chose sodium because it is the stroke, because it is the cardiovascular outcome that is most sensitive to blood pressure and ought therefore to be most sensitive to a sodium reduction intervention. And it would also be very meaningful to users of the research, whether they be the direct population under investigation, policymakers in China who have to pay for stroke care, or indeed other researchers and policymakers around the world interested in the issue of sodium reduction. Move to the next slide. Outcome of ascertainment and being sure that what we've actually detected are strokes is clearly going to be key. We want a method that allows us to detect all the strokes and only to detect the strokes, so sensitive and specific. And in line with usual practice for these sorts of outcome trials, we put in place an adjudication committee that would review in a blinded way outcome data for all of the cases by looking at medical records and any other available information that we could get hold of. And then let's move to the next slide. While making all these design decisions, we were continually thinking about what is going to be the impact of this study if it shows a positive or a negative result at the end. And while we had to make a number of compromises in terms of the likely perceived generalizability of the trial done in a predominantly rural Chinese population, we felt not unduly cowed by that, because we felt there was a very strong evidence base suggesting that the effects of sodium, whatever they are evidentially generalizable across pretty diverse populations. And so while we would test the hypothesis in this specific population where it was feasible, actually we could make a pretty strong case in the end that the data would be fairly generalizable. So to move to the next slide, I'm just now going to talk you through the project that we ended up with, which we call Salt Substitute and Stroke Study, or SAS. And there is a design paper and baseline data published, and the citation for that was listed at the beginning on my prior slide. So if we move to the next slide, the aims. So the primary aim is to evaluate, among a high-risk population, the effects of sodium reduction achieved through the use of salt substitution on the risk of fatal or non-fatal stroke. We specified a couple of other secondary outcomes, major vascular events. This is sort of the standard outcome in most cardiovascular outcome studies of drug therapies, combination of stroke, acute coronary syndrome, or vascular death. And we also pre-specified total mortality, clearly a very important definitive outcome. There is obviously a risk, a potential risk associated with the use of salt substitution, and we defined hyperkalemia as the key safety outcome. Move to the next slide. The design, we ended up opting for a large-scale cluster randomized controlled design done in rural China with the village as the unit of randomization. And you can see in that schema that we did the trial in 5 provinces in northern China. Within each province, we selected 2 counties, 60 villages from each county, so 120 in each village. And then we selected 35 high-risk individuals from within each village who would be the index cases that we would provide the intervention to and assess the outcomes upon. So this served for a population of 21,000 people in the study. Move to the next slide. In terms of the people that we put into the study, we put high-risk individuals who either had a prior history of stroke or were older, above 60 years, and had elevated blood pressure levels. We also required them to have ownership of a phone or for their household member to do that to ensure that we would be able to get good follow-up. And we elected to recruit as many individuals as possible with a history of stroke, aiming for about 2/3, primarily because of the feasibility issues and the need to have a high event rate to maximize statistical power. The next slide. This slide just mentions some of the exclusion criteria. So because we were delivering an intervention that was potentially going to affect the entire family unit, in other words, the salt substitute, we had to be careful to make sure that neither the individual, the index case, or any family members had any contraindication to the use of salt substitute. And we also wanted to make sure that we had a participant group who were eating most of their meals within the household and would be affected by the intervention. The next slide, randomization, was done centrally using a computer program, stratification by county. Randomization, importantly, was done only after we'd recruited all of the individuals within the respective village unit. The next slide, please. The intervention was a salt substitute provided free of charge to the intervention group participants. Again, because we didn't have sufficient funds, we were unable to provide salt control to the control villages. So this is an open study design. And we used, in parallel, education to try and also encourage the participants to reduce the amount of salt substitute that they use compared to prior salt consumption. The control group, we left usual care. The safety, the next slide. So salt substitute is generally considered safe, but can cause hyperkalemia if consumed in large quantities or in people with serious renal impairment. And as I noted, we spontaneously recorded hyperkalemia events as the primary safety outcome. Next slide, follow-up. We planned initially to see participants every 6 months to assess outcomes. Initially, we wanted to do that by telephone. We found that in practice this was quite difficult. We then switched to face-to-face, and we now, because of, again, financial constraints, are using primarily routine collected data to screen the events, followed by face-to-face in those with suspected events. We also collect data from a random sample every 12 months of about 1,200 individuals to assess intermediate effects on urine blood pressure and use of salt substitute indicators. Next slide. We have put in place a masked endpoint adjudication committee, which uses documentation that we source from a range of different sources to adjudicate each of the suspected events. The next slide. The statistical power that we settled on was 80% power, two-sided alpha of 0.05, to detect a 13% or greater relative difference in the risk of stroke between the groups. And that assumes 600 clusters, one-to-one randomization, 35 high-risk individuals in each cluster, 5-year mean follow-up, 3.5% per annum stroke event rate, and a difference between the intervention control groups of 3 millimeters in systolic blood pressure. And then the ICC is the intracluster correlation coefficient, which relates to the cluster randomized design. We were able to calculate that as 0.04 based on the pilot data that we had. Next slide. We have an interim monitoring committee, a safety committee. So we have an interim monitoring plan, as I alluded to, whereby the steering committee reviews the overall outcome event rate and unblinded data describing the effects on the intermediate outcomes to understand whether we are achieving our power objectives. The next slide. And we also have a safety monitoring committee who review for us unblinded safety data about the effects on the hard outcomes every 12 months. And they will let us know if we should be causing harm or benefit that would require us to discontinue the study prior to the scheduled 5-year follow-up. And then just to finish off, next slide, current status. So we completed recruitment. We have 99% complete follow-up for the primary outcomes at 24 months through the face-to-face visits. We're now in the 3rd year of follow-up. The blood pressure difference between groups is slightly greater than we assumed with power. The suspected stroke event rate is far above the assumption, but the adjudicated event rate without all events currently adjudicated is slightly below, but should hit the assumed stroke event rate. The next slide and final slide, the current challenges that we face primarily relate to funding for the project and the ability to collect the data in a timely way that we require for outcome event adjudication. But broadly, we are on plan, on track to meet our objectives as planned, and the study should complete in about 2 years' time. So I'll, final slide, stop there. Thanks very much for listening.